Thank you, Evans, for giving this opportunity. I'm going to talk about the neck of femur fracture in a non-union shaft femur, a double trouble type of injury. So let's begin. This is the case. 33-year male patient, right hip pain and thigh pain. History of high velocity injury before 6 months in August 24. Is a non-smoker with no medical comorbidity or other associated injuries. Clinically, the patient was unable to do SLR, and there was signs of shortening of the lower limb and with no signs of infection at present. Blood report was normal and MRI was done which showed a viable femoral head. So there are functional problems. There is a pain in the hip and the thigh region, difficulty in weight bearing and limb shortening as seen by the transischial line. There are also radiological challenges like non-union segmental shaft femur with a sclerotic edge, untreated neck of femur fracture, Powell type 3 as seen in this case, and there are also management challenges like high risk of AVN, poor bone biology showing resulting in delayed union or non-union at the segmental shaft femur bone. There is a very good paper by European Journal of Orthopedic, and they have studied the incidence of complication and functional outcome of the literature in December 23, and they found that such kind of injuries they have limb length discrepancy, biomechanical instability, and they are sometimes associated with young age, and those so that's why there was having a high functional demand in such cases. Also, there are signs of infection in such cases. So we did a planning. We planned for a two-stage surgery. In first stage, we'll do removal of implant. We'll do the freshening of the sclerosed margin, cortical decortication type of thing, and reduction of the fracture size with TPW, proper size distal femoral nail, and a cancellous bone graft from the iliac crest. In second stage, we'll go with the salvage surgery for the neck femur, and as per the Santos criteria, it fits in the type 1 as the proximal fragment is more than 2.5 centimeter with no signs of AVN at present. So the patient was placed in a supine position in a table, and the cortical decortication is seen in the video. We also did a reduction of the fracture with the help of the clamp and a strip in for a temporary reduction and maintaining, helping the pin to get passed in the central alignment in AP and the lateral view. And also, this is a clinical picture showing the tension band wire and the distal femoral nail which has been placed through this wound. This is the IITV images of the AP and lateral view with reduced fragment with the help of the tension band wire. And this is the immediate post-op as seen in these X-rays. We have used a polar screw so that we get in central alignment in the AP and the lateral view in this case. And this is a clinical picture at the 7th day of the post-surgery, and you can see there are no signs of infection at present. Wound is clean and dry, and therefore we did an planning for the ABP and the osteotomy. And in this case, we want that it should get convert Powell type 3 into Powell type 1. So the angle may get reduced from 65 degree to 25 degree. And accordingly, this was planned with the help of the article which was published by Ashok Gavaskar in 2019. They did the valgus intertrochlear osteotomy for femur neck pseudoarthrosis. And this was the planning which was done. Powell angle which was calculated to be 65 degree. Osteotomy angle was planned about 40 degree. We tried to keep it near 30 degree. The guide pin insertion angle came to be 100 degree, and the supplementary angle which came from 120 minus 120 resulted in 60 degree of the angle. So this is the IITV image. We have placed the guide pin first in the superior portion in the AP and the lateral view. A corticocancellous screw was passed so that it helps in preventing the rotation of the proximal fragment. This is the lateral view of the same. And the guide pin was inserted for the placement of the 120 degree angle blade plate, which was aiming at the 100 degree. The chisel was passed. In the lateral view also you can see the placement of the chisel was further introduced in the proximal fragment. And this is the lateral view of the same. And then the osteotomy guide pin were placed at the level of calculated angle, which came to be around 30 degree in this case. And then the 120 degree angle blade plate was introduced and then held with the reduction clamp in the distal portion, and then the screw was passed from the plate through the nail to the opposite cortex, which gives a very stable fixation. And this is the immediate post-op X-ray showing the well-reduced neck femur and screws which were passing from the nail through the plate. This is a 3-month post-operative X-ray. This shows where signs of callus formation and signs of union at the neck fracture site. These are the functional outcome. Patient is able to sit cross-legged, stand on the operated side. And these are the 6-month post-operative X-rays, and it shows that the neck femur it has healed completely, and segmental femur shaft is also healing very well without any signs of showing very good signs of callus formation. These are the functional movement of the same patient. You can see patient is able to do SLR. There is no limb length discrepancy. Sit comfortably, cross-leg sitting, and he can also stair the climbs. Also, he can come down through the staircase without any support. So post-operative management, again, we have to be very cautious for early mobilization. Also, you can give a DVT prophylaxis. You have to monitor the signs of infection and also for the signs of avascular necrosis. Limb length discrepancy assessment should be done properly. So in summary, you have to plan properly. Segmental shaft fracture needs reduction and stabilization with proper size of interlock nail, and add reduction technique before nailing to achieve length, alignment, and rotation. Take piriformis entry and be cautious for the neck fracture because incidence is about 19 to 13%. So always do screening in IRTV after interlock nailing, and in untreated and missed neck fractures, use Sandhu's criteria to decide for salvage procedure or replacement. Thank you once again.